that Professor Stefan Stättner from the famous hepatobiliary surgery team from Innsbruck, Salzburg, currently associate professor at the University of Salzburg, this is right, is now presenting the topic patterns of recurrence after surgery for extrahepatic cholangiocarcinoma.
Thank you. Thank you very much for these kind words. So let me thank the organizers and also congratulate the organizers for this fantastic meeting. It's a great honor for me to talk among these really famous speakers. So I just moved to Innsbruck, and I'm probably one of the very few dedicated HPP surgeons in Austria. And I did part of my training in the UK in 2011. So I have no disclosures. So when I got this title, I thought, well, what does it mean? Tried to interpret and made up my mind. And I thought probably this is questioning quality of surgery, which is a main point in my talk. How good is our service we provide to the patients? And I think centralization is a really important part, especially in the HPP area. So we need high quality surgery that is clear to reduce local recurrence and distal recurrence rates, probably difficult to answer. And let me mention, I will do this several times in my talk, but it's always a multimodal approach. It's very important to get all the different experts in this field on board for the patients. So the second thing is, of course, recurrence matters, because patients die of recurrence and they also suffer from recurrence. So what we need in future, and the previous talk was fantastic, for me as a surgeon, very difficult to understand, but I think we need tailored approaches for the future for neoadjuvant and adjuvant therapy. We need to pick these patients out who really benefit from that. And we should focus on more local and also systemic treatments in the future, because as up to date, we only have one therapy after resection and for palliative treatment. So this was my first agenda, brainstorming. You see, a lot of topics you could talk about, but of course, don't worry, I will only talk about the classification systems. I think this is necessary. Some of those you have already heard in the previous talk. And then I will talk about current treatment standards, some guidelines and risk factors for survival and recurrence. If you expect me to bring you high quality data, that is what we used in some other diseases, and I have to tell you that the data in terms of good evidence is very scarce. Because why? It's a rare cancer with low numbers. So if you look at the studies, the numbers are low, and it's usually a long time from single centers. They're looking at patients. It's always a retrospective design in the single center series, and we are sometimes comparing apples with oranges, I would say, and different populations. Most of the studies are from Asia on this specific topic, I have to say. So what about classification? Do we speak the same language worldwide? And we've heard about that. So usually we have the intrahepatic cholangiocarcinoma. This is not my presentation. And we have the perihilar and the distal cholangiocarcinoma. They are together called the extrahepatic cholangiocarcinoma. Gallbladder cancer is something different, also in terms of biology. And the cancer of the cystic duct, I've never seen that. I don't know if you can really differentiate, but this is counted to the gallbladder cancer group. The annual incidence, I said it's a rare cancer, it's about 5 per 100,000 per year in the US. So that's quite rare. And about epidemiology, so the intrahepatic side makes about 10% of the cholangiocarcinomas. I think they're on the rise. We heard that before. Most of them are coming from the perihilar region, and about 40% are coming from the distal region. If you look at the HACC staging system, they differentiate between perihilar and distal extrahepatic cholangiocarcinoma, so that's a difference. How do we classify as surgeons? The worldwide mostly used classification system is the Bismuth-Colette, which is quite old. And it's probably not the best we can use, but it's probably quite simple for us to optimize our treatment strategy. But there are several other classification systems out there, from the Mayo Clinic, for example, or Memorial Sloan Kettering Center, and probably the most tough one is this one, published in 2011 from the IHPB group from Zurich. And you can see it's very important that you need, because it's a very sophisticated anatomical area with a lot of very important structures there. So you have to look in detail and look at your arteries and also the portal vein, and the liver you have to resect. And this is just one example, just did 2 days ago in Innsbruck. So what's the difference, of course, between central or hilar cholangiocarcinoma and the distal one? It's a major difference in terms of surgical approach. So, of course, if it's here, it's a hilar one, then you always need to do a liver resection. It's a big difference, of course. If it's in the middle, it's sometimes a CBD resection is enough. So a common bile resection might be enough, but this is, I think, quite rare. Sometimes, of course, if it's a distal, then the Whipple's procedure is the treatment of choice from the surgical point of view, and in some cases you might need both. And there are many different topics you need to talk about, and if you look at the NCCN guidelines, for example, then they say you should consider explorative laparoscopy to exclude patients. You should do, of course, frozen sections during surgery, so you need a good pathologist on board. And regional lymphadenectomy is always recommended in cholangiocellular carcinomas. And the very important thing again is, I think, in this area, I think every HPB resection needs centralization. I think that's the main key. Not only because the surgeon can do it, but you need the support of the team, and you need people who fix your complications. It's very important. This is just one case we did. This is a left hem hepatectomy with the Whipple's. The liver is quite small, atrophic liver. So he did quite well, but he had, this guy, for example, had very early recurrence after 1 year. So coming back to the perihilar cholangiocarcinoma, the facts. So the incidence is very low. It's 1 or 2 per 100,000 per year. So if in Austria, for example, we should approximately have about 80 to 100 cases a year for the whole of Austria. The diagnosis is very challenging, as you all know. It's not easy to assume that the patient is resectable or not. So you need good radiology, you need endoscopy, interventional radiology. You usually need pre-op biliary drainage. This is a known topic. You can talk about this topic the whole day, I would say. And you always need major resections in these cases. And sometimes, you all know the Mayo Clinic, the data from there, it's highly selected. In highly selected cases, they transplant with very good results. The resectability rate published is approximately 20 to 30%, even in high volume centers like, for example, in Berlin. And still, and that's a major point, if we discuss with our patients, the mortality in this specific kind of operation is still 10%, even in large centers. The only ones who publish better data are the Japanese. They come down to 4 or 5% perioperative mortality. So this is just what we do, just that you know that this is a major resection. Of course, if you have a tumor here centrally, then you either need to do an extended left resection, which is probably the most difficult operation there is, very often combined with vascular resections. And you have to cut, or the other approach, you leave segment 2 and 3 behind and take out 2/3 of the right side of the liver. And you also have to cut the bile duct, of course. That means that you have to do, at the end, a reconstruction of the biliary outflow. So high-risk operations, they should only be done in centers, in my opinion. So more facts. Up to 50%, if you look to literature, are ending up with an exploratory laparotomy, like the case we did 2 days ago. I put the laparoscope in. I didn't see any extrahepatic metastases or any hepatic metastases, so we proceeded to surgery, but finally we couldn't make it because the whole, not only the inflow, but the trunk, the common trunk was surrounded by tumor tissue. So this is quite common. Median overall survival after potentially curative resection is 38 months. If you transplant highly selected cases, but this is only done at the Mayo Clinic and in some US centers. The Irish tried to reproduce the same study, the same design, but they failed because 30% of the patients died after surgery, so they had to stop the trial. This is a review from Yumin Fong published 2014, and it says, you see, these are the multivariable analysis risk factors for survival. So lymph node metastases, hazard ratio 2.3, and positive surgical margin is 1.5. So this is the only thing in real life that we as surgeons can try to aim and to make it better. All the other things, of course, tumor-induced, patient-induced. What about the recurrence patterns in Highrisk cholangiocarcinoma? The recurrence rate is very high, as you can see, up to 70% after median of 20 months. And you have to take into account that these patients, it takes them at least 3 months to fully recover. It's a long time. The local regional recurrence, if you just look at the local regional area, is up to 60%. That's quite high, and I will come to that later. The risk factors for recurrence is advanced local disease, nodal disease, low differentiation grade, and in the explanted livers, they did worse. Those cases did worse who had perineural invasion on the explanted organ. Now let's go to the other parts of the hepatic ducts. This is I will present you just three papers. This is a paper from Korea, published in 2012, and this paper is interesting because they look at the natural course of the disease at the early site of recurrence. But the problem, as I said before, they mix up all biliary tract cancers, like gallbladder cancer, intrahepatic and extrahepatic, and this group consists of hilar and distal ones. So it's a mixture. That's the problem if you want to analyze the data. And this is the baseline characteristics, and you can see the significant results here in this group, because this was my main topic to talk about. So lymphatic invasion was more common. These patients had a higher level of CA99. They had a high grade of perineural invasion, and they had a higher chance of having a R1 resection on the final specimen. And also they did more adjuvant therapies in these patients, and preoperative interventions were very common, meaning that they needed biliary drainage procedures. So looking at the patterns of recurrence, so if you just focus on the extrahepatic cholangiocarcinomas, and you can see that 43%, so almost half, have a local regional pattern of recurrence, first of all. And 57% have a distant or a local regional and distant. So what does this mean? Probably, I don't know. So do we have different phenotypes, genotypes? Do we need to treat this more aggressively if it occurs? And I think all of you have seen patients that survive very long, even without treatment. And this is the time to recurrence. This is probably also interesting if you want to tell the patients. So it seems that the time to recurrence is a little bit longer in the extrahepatic cholangiocarcinoma than in the intrahepatic or the gallbladder cancer. And these are the figures. So the total time to recurrence is 13.1 months in this study and 14.1 for distant recurrence. So it takes a little bit longer. And the median overall survival is very good in this study. It's 49 months, very good result. If you look at multivariate analysis just for the distant pattern of recurrence, then you can see that lymph nodes in this study, positive lymph nodes, lymphatic invasion, and a high level of CA99 was positive as a poor prognostic factor. And the resection margin was not significant in this study. Another study from Italy, it was done by two major HPP centers, Verona and Bologna. It's a huge series, probably one of the largest series published, but again, long period of time, 26 years. And the Whipple procedure, the pathology changed a lot during this time. And there were the three divisions of surgeons. So this is the postoperative complication rate. So that's why I put this on, because in this trial, they also looked at postoperative complications. I think this is also something we need to take into account. We need to be safe. And I think what we could show in the paper with Serge Evra, with Memorial Sloan Kettering, when we did ablation and resection in colorectal liver mets, that those who had complications did worse. I think this is also a topic we need to look at in the future. I don't know if you're all aware of this Clavier-Dindo classification we nowadays use. So if a grade 1 says this doesn't change the way the patient goes, probably if you have a wound infection, you just open up the wound bedside and that's it. Grade 2 means that you, for example, need antibiotics. And grade 3, here, these are the more serious complications. This means that you have to do any re-intervention. So 3A is usually if you have to put a needle in somewhere. Grade 3B would be if you have to take them back to theater, and grade 4 means that they're really significantly ill. For example, ICU stay. So they looked at this. That's why this is probably also interesting, this study. And you can see that the complication rate is quite high. Although grade 1 is very low, so I don't really believe this. It must be high. I just can't believe this. So the overall morbidity was 40% in this series, and the 90-day mortality 5%. So we're still having mortality in these patients. So this is the survival data. It's a little bit complex, so I put this out. And here you can see that the intrahepatic cholangiocarcinomas did better than the extrahepatic ones. You can see this here. And in this series, the median overall survival was only 23 months. If you could compare with the last study I showed, it was 48 months, so a major difference. Probably this is population-based. Probably the Asian patients do better. On the, I don't show you the univariate analysis, and on the multivariate analysis, only macrovascular invasion was significant prognostic factor for survival. And the last study I'm going to discuss with you is now focusing just on middle and distal, so no hilar cholangiocarcinomas. This is again a study from Seoul in Korea. They looked at 137 patients. It was a consecutive series again, the time period of 7 years in a single center, retrospective analysis. So what they've done, you see, out of these 137, 125 came to resection. This is a resection rate of 91%, which is quite good, I would say. In some, they did some palliative procedures. They didn't resect. I think we also need these patients to see the difference in ultimate survival at the end. And out of these 125 patients, 1/4 was only treated with a segmental bile duct resection. So the key features of this trial, I think it's quite good. It's a very tight follow-up. They're discussing that. 90% of these patients needed pre-op drainage, biliary drainage procedures. And they also discussed what they've done with the patients. So many of them had adjuvant chemoradiation for advanced disease, adjuvant radiation for R1, and adjuvant chemotherapy in 14 cases. So this is, for example, what I was missing in the prior study from the Italian group. Mortality in this study was 4%, so still it's not zero, of course. Morbidity 90% just for the local resection and 40% for the Whipple's procedures. 5-year survival in this series, median of 35 months. So somewhere in between the other two trials I just discussed before. This is some additional data from this study. You see there is a difference if you resect these patients R0. It's a significant difference versus R1. And of course, those patients that only had palliative procedures, they don't even survive 2 years, so they all die, no matter what you do. Then they looked at lymph nodes. It doesn't matter what you can see here if you count 2, 3, or 5 positive. The matter that a lymph node is positive is a significant risk factor, at least in this study, for bad survival. And this is the multivariate analysis of prognostic factors again in this series. So you can see, so poorly differentiated tumors are doing worse, 5.8 hazard ratio. Lymph node metastasis is positive. You can see this here. And also the pre-op bilirubin, that even if they had a drainage, 90% had a drainage, if it doesn't come down prior to surgery, then these patients do not well. So now, then they looked at the patient that had a recurrence. So this is the disease-free survival. Here are the figures, and you can see that after 2 years, the curve is flattened. So probably the follow-up time was not enough, I don't know. But so it doesn't come down to a later stage. So most of the recurrences seem to appear in the first 2 years. This is also something you can probably tell your patients. And they looked also at those patients who had a recurrence, and the time the median time of survival was 8.9 months after the recurrence occurred. And again, they divided the two groups who had further treatment. They lived longer, significantly longer than the ones who had no treatment. And now looking at the patterns of recurrence again, this was my topic, you remember. So again, you have a high rate of patients who have just localized recurrence, 35, and 39 who have distant recurrences. Most of them in the liver and secondary in the peritoneum. So probably, I think, we need to focus in this area on aggressive local treatments, radiotherapy combined with chemotherapy, probably ablative procedures. And for the distal, of course, we need systemic treatment. And I think we need to push this forward because in my experience, I see a lot of patients who had that treatment. They had cis and gem therapy, but they are really well, and we need to give these patients some additional treatment. So as I summarize my talk, I think it still is clear that surgery remains the only chance, the only potential chance for cure. The 5-year survival rates I've shown is a few data at least are in between 20 to 40% after curative intent resection. Some patients even live longer. The R1 resection rate is still quite high. This is where we as surgeons need to be aware of. So in my opinion, especially Gladskin tumors, it's always better to aim for a broader resection, a resection margin. Because otherwise you won't help the patients, just the risk. And the node-positive tumors are more common in the extrahepatic cholangiocarcinomas. Microvascular invasion is more common in the intrahepatic. Recurrence, as I showed in the last paper, is very common within the first 2 years. And this also has, of course, an impact on quality of life, because if it's a local recurrence and these patients get jaundiced again, they have cholangitis, so they're really ill, and you can't treat them in terms of chemotherapy. This is probably the reason why many patients of those didn't have any treatment. There are probably distinct geno or phenotypes, because there are patients that only recur locally, so we have to focus on that, in my opinion. And also we as surgeons, that's the second main point, what we can do, we need to focus on surgical morbidity, because I think there is a major impact on outcomes. And the perspectives from our point of view, we need preventive strategies. This would be ideal, because most of the patients come too late. Resectability rate is 20 to 30%, as I said, so most of them are palliative upfront. We need this center-based approach. I think every cholangiocarcinoma needs to go to a center. It's probably different with metastatic disease. You can do right hemipodectomy, whatever. But this disease needs to be in a center. What we need probably in future, we need to work on that. We should stratify our patients who really benefits from neoadjuvant treatment or adjuvant treatment. I think we need to work on that. We should collaborate more. I think this is the best way to do it. EORTC meeting yesterday was a great pleasure to be here. And I think we need more translational research to understand the disease better. And then this will, of course, help us in stratifying the patients and help us probably in the future to prevent, to set some preventive measures. Thank you.